today is our annual review on bloodborne pathogens. We'll be introducing our speakers today, so please join me in welcoming, first off, Louise Dembry. Dr. Dembry is a graduate of the Wayne State University School of Medicine, where is also where she completed her residency in internal medicine and infectious disease fellowship. She came to Yale after her fellowship and is a professor of medicine and infectious disease and epidemiology. She served in a variety of roles at Yale New Haven Health Hospital and the health system, including hospital epidemiology and emergency preparedness, prior to joining the VA Connecticut healthcare system in 2016, where she is the hospital epidemiologist. Also joining her today is Dr. Russi. Dr. Russi is professor of medicine epidemiology at Yale and is the medical director of the wellness and employee health for the Yale New Haven Health System. He has acted nationally on issues of healthcare worker safety and has authored a number of guidance documents and currently serves on 2 federal.
And again, just a reminder, you're here for your annual training, so don't forget to put in for your CME credit. That's how you're going to be tracked for your attendance. So it's very important. This is required by OSHA every year. All right, bloodborne pathogens. We're going to be talking mostly about hepatitis B, hepatitis C, and HIV this morning, but I think it's important to remember that there's a list here of some other bloodborne pathogens, but there's probably at least 20 other pathogens I don't have listed on the slide. So it's not just about what I call the big 3, but the same principles apply to these others. All right, modes of bloodborne pathogen transmission in healthcare settings. So percutaneous, which is what we're mostly going to talk about this morning. So this is going to be Sharps injuries, but also it's important to remember there can be mucosal exposure to blood or body fluids, and then there's also the possibility of direct inoculation of virus into anything where that's broken skin. So that can be scratches, lesions, abrasions, or burns. With exposures, the risk of infection varies with the pathogen that's involved, the type of exposure, and the amount of blood involved in the exposure, as well as the amount of virus in the patient's blood at the time of exposure. And I think Dr. Russi will talk a little bit more about that in his part of the presentation. Okay. So here's some data from 2020. EpiNet is a very large group that collects data from a variety of sites around bloodborne pathogen exposures. And most of the exposures, or almost half, are occurring in the operating room. So it's certainly very relevant to the surgical group. And about a quarter occur actually in a patient room or in an exam room. A quarter almost of all these devices causing injuries are from suture needles, and then 16% or so are disposable needles, and then a smaller percentage are blood collection needles. To give you some context, in 1996, it was estimated there were about 1 million bloodborne pathogen exposures in the United States among healthcare personnel. And then by 2000, there were about 385,000. And the biggest decrease had been in disposable syringes, as well as blood gas collection devices and butterflies. This had been tremendous improvement here, but there had been very little improvement in suture needle exposures. And just a reminder around bloodborne pathogens that also got to think about mucous membrane exposures, and the most common one is to eyes, and that's where eye protection becomes very, very important. All right, so when does a bloodborne pathogen exposure occur? Half of them occur during use. And I think it's important to note that about a quarter or so also occur what we say downstream from use into the non-user. So that can be at the time when somebody is maybe cleaning up. This would be in the case of the OR, cleaning up after a case. This can be needles that are disposed of incorrectly, and then an environmental service worker is exposed, those kinds of things. So we've got to think about also the downstream risks to others. What are the devices that are most commonly associated with Sharps injuries? So as I comment, and suture needles are about a quarter, disposable syringes are about a quarter as well. And then also scalpels make up about 7%. And then there's a whole variety here that go into the other. Some of them are listed here. So that's also a large group, but this is certainly the largest group is disposable syringes and suture needles. All right, so this was a study looking at actually trainees and reports of their bloodborne pathogen exposures and Sharps injuries, and where they said they were most commonly injured. and it's generally the left hand, so the left index finger and middle finger is most common, and that's because scalpels in syringes are, suture needles and scalpel blades were high on this list here, and so that was essentially, since most people are right-handed, that was where they were sticking themselves and then to their left hand. But there are also exposures to the right hand, but most of them have been to the left hand. All right, so about a third of Sharps injuries occur in the OR. That is still true today. I showed you some of that data, with suture needles being the most common. But also too, that 78% most commonly are the ones that are without safety features. It is also possible that in some cases, especially some of the older devices where safety features have to be activated, where there's an exposure because, or an injury because the safety feature was not activated. But in general, the Sharps injuries are from those devices without safety features. Most commonly been surgeons, but also we've got to think about scrub personnel, anesthesiologists, circulating nurses, and some of these are people on groups of, as I said, in the downstream effects. All right, so I'm going to just show you a couple studies. I've shown these in some previous years in giving this talk. This was one that was a large academic teaching hospital looking back at 10 years of their bloodborne pathogen exposures. And they looked at the overall bloodborne pathogen exposure per 1,000 surgical procedures. Overall, on average, it was 6.3 per 1,000 surgical procedures. They also broke it down by type of surgery, and urology actually came in there at, I think it was 6.4 per 1,000 surgical procedures, so right in the middle. What they did find in this is that there were the bloodborne pathogen exposure rates were increased with increased patient blood loss, as well as the number of personnel working in the field and the procedure duration. This association was generally strongest for suture needle related exposures. What's most important on this slide, I think, is again commented on suture needles, but also is generally the #1 group that reported or had bloodborne pathogen exposures were fellows, residents, and students, and second to that were attending physicians, and the others, which made up a much smaller proportion of injuries. This is another study that was looking at needle stick injuries and attitudes about risk. And so this was a group that had done a similar study in 2003, and so compared that to a study that they did later. It included medical students and Department of Surgery staff. A little over a third reported that they had had Sharps injuries. Most of them occurred in the OR, and 11% of those were considered high risk. What was interesting, I think, in this is that not only a third had at least one unreported needle stick, but almost a third reported that they were actually stuck by another individual. And so we'll talk a little bit about the operating room setting and some of the challenges there, because it's really a team working in a small area. And so getting stuck by somebody else is a risk there that don't get so much outside of the operating room setting. Half reported that they felt that it was due to something where they were being careless, it was accidental, and about a quarter felt that they were rushed, and that is why they had an exposure. When they were asked about why they did not report needle stick injuries, the vast majority responded basically that it was inconvenient and too time consuming to do. And then there were those who said they didn't feel there was a utility in reporting, so they didn't feel that there was really any follow-up that needed to be done. And then there were those who felt that there was a stigma of having had an injury, and that somebody might think that, you see that as an error on their part and did not want to report it. And this also correlated with what their perceived perception was around risk. And those who felt that there was, a higher risk based on the individual, they were more likely to report, and also less likely to have had a needle stick injury, and probably because they took more measures to protect themselves, versus those that felt that the risk was lower than it actually was. And what I think is interesting here is a fair number of the participants actually believe that the incidence of seroconversion after an exposure, so seroconversion to HIV, hepatitis B, or hepatitis C, was actually lower than reality. And so they were not understanding the risk as well as they should. 79% said that they always double gloved. What's interesting is it was pretty high for medical students and it went down further in fellows. Again, this is not specific to urology. This is across various surgical specialties. And about half at this point in time felt that there was a need to double glove. 80% always wear eye protection. We'd like to see that get up to 100%. And interestingly enough, 80% had received hepatitis B vaccine, but when this was looked at by medical students in 2003, their hepatitis B vaccine uptake was almost 100%. I think it was 98%, 99%, and it actually had dropped down to just under 80% later. And so maybe again, because there was much more control in the community around hepatitis B, because there's so much vaccination, they didn't perceive the risk for themselves and were not getting hepatitis B vaccine, which is an important vaccine. So needle, stick, and sharp injuries. This is in orthopedics. It showed similar things that we've talked about before already, that suture needles were very important in this group. And let's go to the next one. I think the bottom graph here is the one that I think was important, and it's similar to the previous study I just showed you. These were factors that affected their reporting of a needle stick injury or sharps injury. And it was, again, their perception that the patient could have a communicable disease. The time required to report, how busy they were, also played a role. But their, again, perception of risk was one of the big drivers as to whether they would report a sharps injury or not. Some of the predisposing factors to sharps injury in the operating room that they looked at in this study was physician factors. I don't think I have to go through all of these. You're probably very familiar with them. Again, instrument factors, lack of safety devices is an important one, or failure of the safety devices. This is in cases where the safety devices had to be activated. And then environmental factors. So emergent cases, not surprisingly, sharps injuries are more common there. Patient instability, the longer the procedure, I showed you another study that already showed that, and procedures that were done what we would consider kind of off hours or evening or night procedures. And then these are some of the strategies for preventing or controlling these hazards in the operating room. So sharps alternatives, safety devices, a neutral zone for passing sharps, double gloving, and also here protecting for mucous membrane exposures, remembering eye protection. And Dr. Russi will talk about some of these things I think in history. All right, so you are here because OSHA says you have to do annual training. OSHA did put out a bloodborne pathogen standard in 1991 and said every healthcare facility has to protect their healthcare personnel from injuries and exposure to bloodborne pathogens. And so I have to have an exposure control plan, have to have control measures that isolate or remove the hazard from the workplace. And so a lot of that are the safety devices, work practice controls, and then personal protective equipment, which is part of the hierarchy, but these are the most important ones. The work practice controls, an example would be, which hopefully nobody is doing at this point in time now that we're almost 30 years into this, it would be like recapping needles, which is a big one. So we now follow standard precautions, used to be called universal precautions, but in 1995 it was changed to standard precautions, which basically says that take precautions for the care of all patients, regardless of their presumed infection status. And that is for all blood, body fluid, except sweat. You need to consider that it could be potentially infectious. So important in standard precautions is hand hygiene. I'll take a minute and talk about that. Gloves, masks, eye protection, gowns, and then there's things we're not going to talk about today, but patient care equipment, environmental services, and Dr. Russi will talk about injury prevention. So hand hygiene, I kind of try to block these into all the before activities, and after activities. And so this isn't all patient care. It's not specific to the OR, but before touching a patient, before putting on gloves, before doing invasive procedures, before handling clean equipment and supplies, when examining a patient, going between body sites, say from an infected wound to a clean wound, another body site, after touching the patient, touching the environment around the patient, after handling dirty equipment or supplies, and then these, which I call personal activities, before eating or drinking, after using the restroom. There are long lists of when you should do hand hygiene. I think they tend to be overwhelming for people, so I try to break it into this as kind of these basic ones. If we did this 100% of the time, our hand hygiene compliance, if when we need to do that, would probably be somewhere in the high 90%. And I think we all have a long ways to go to get there. Soap and water hand hygiene continues to be acceptable. I think we're so used to using alcohol-based hand rub that people forget that soap and water hand hygiene is perfectly acceptable. Very important to do it for the right amount of time, 15 to 20 seconds, cover all areas of the hands, between the thumbs, tips of the fingers, the palms, etc. And then I think you're all familiar with waterless alcohol or emollient-based products. Very easy, you don't need to have a sink. It saves a lot of time. Again, the same thing, you need to make sure you cover all sides, aspects of your hands when doing that in order to be effective, and then rubbing till it's dry, because if you just let it air dry, it's not actually working the way it's supposed to. And these are the areas that are frequently missed when people do hand hygiene. So as I said, just think about getting between your fingers, fingertips, thumb, palm, all the way down to it. Certain times that alcohol-based hand rub should not be used, and that's when hands are visibly dirty, or you've gotten blood or body fluids directly on your hands, say that a glove tore, or on taking off the glove, you realize that there was a break in there and you've got blood or body fluids on your hands, then you should use soap and water. And the other time, from an infection prevention standpoint, is after you've taken care of a patient who has C. difficile. All right, some other personal protective equipment. You talked about the major component standard precautions and protecting skin and mucous membranes. So a lot of that is your eye protection. And really important is removing all PPE before you leave any treatment areas. So when do you wear gloves? That's when you anticipate that you may have contact with blood, body fluids, including saliva, touching mucous membranes. The only body fluid you don't have to be concerned about for transmission, at least from the pathogens we know about now, is sweat. Remove gloves after patient care, perform hand hygiene, remove the gloves if you put them on and you see that there's tears or cuts that have been punctured, and wear a new pair of gloves for each patient. We still sometimes see people go from patient to patient with the same pair of gloves on. Not only is that not safe for the patients you're caring for, but it's also not safe for yourself. And gloves are not a substitute for doing. All right, so gowns. Gowns are to protect yourself, your clothing from potential spray or splatter or direct contact with blood or body fluids. Gowns must be tied at the waist and at the neck. And if you're at a facility that has a gown that just kind of goes over your head, then it's already done for you as far as tying at the neck. But you also still, in all gowns that I know of, still have to tie at the waist because you want to make sure that you have good coverage for your clothing. And then wearing a surgical mask and eye protection. Given we're in the time of COVID, this should be a constant, and so we're kind of doing standard precautions all the time, and then we're wearing surgical masks, and then certain times we've also added eye protection. All right, regulated medical waste. Very important that sharps, since we're talking a lot about sharps this morning, be disposed of in designated needle disposal containers. They all look different at different times and at different vendors. So this is a picture of one type, but most important is they almost all will have a fill line. It's usually where it's 3/4 full. And if you see that the container is at the fill line or higher than the fill line, don't put any more items in there, because there is a potential risk that you could get stuck from something in the container if you try to force something in there. Most containers now are designed in such a way that things can't stick back out, but don't take that chance. If you see that it's full, go dispose of your sharps in another container and let somebody know this needs to be replaced. So in the state of Connecticut, what is considered regulated medical waste is anything that's dripping visible blood. And so there you want to contain the fluids where it's possible. And I think about it as anything that's visibly dripping waste, blood, or body fluids would be, even if it was like a wound dressing. If you were to squeeze it, don't do that, but if you can estimate what that'd be. If you were to squeeze it and you could get a drop of fluid from that, then it is regulated medical waste. Otherwise, it's regular trash. And this varies by state. So I'm just telling you what it is in the state of Connecticut. If you're going to practice in other states, you will want to know what is the requirement for regulating medical waste. All right. So in 2001, OSHA updated their bloodborne pathogen standard and to strengthen their requirement of using safety devices. And the thought was because the data was suggesting that there were still too many sharps injuries and needed to try to work on decreasing these further. And sharps safety devices were not being adopted very much by healthcare facilities and healthcare personnel. And some of that was because early in the 1990s, when the bloodborne pathogen first came out, there were some safety devices on the market. And those of you who are as old as I am will remember some of them. They were clumsy, they were hard to use, and some of them actually caused more injury than the non-safety device. And so people tended not to use them. But these devices got better over time. And so in 2001, OSHA said, hey, you know what? You have to look at these devices. And if there is a safety device on the market, you need to include frontline personnel in evaluating that. And you must use a safety device if one is available, unless you can document some reason why it would be problematic and cause harm to the patients, or your personnel say they're just not able to use it or something like that. So you want to use a sharps device, is basically one where you can eliminate either totally eliminate the sharps device. So think about that as like needleless systems. An alternative exists that can eliminate the unsafe feature. And then do recognize, and so does OSHA, that some but not all needles can be eliminated. And so that's where we really got to think again about other prevention measures we can do. It was estimated that about 3/4 of sharps injuries were preventable. This is what you'd like to see in a safety device, that the safety feature is integral to the device, so that it's something that has to be attached to it, that it works passively, meaning that the user doesn't even have to think about activating it, it just works on its own. The user can easily tell that the safety feature is activated. Safety feature can't be deactivated at all and remains protected through the whole disposal process, and it performs reliably and is easy to use and practical. So these would be the ideal device characteristics, and there are some on the market for certain devices that now probably meet all of those criteria. Others meet some of those criteria, and there are still some devices that need to be developed by some smart engineers out there that would deal. So I did see some effects from the Needle Stick Safety and Prevention Act of 2001, and did see decrease in sharps injuries. However, the biggest decrease was in the non-surgical setting, so outside of the OR. In the OR setting, actually, injury rates increased slightly, not an awful lot, but like a 6.5%. So essentially remained unchanged, with suture needles and scalpel blades still being the most common devices causing injuries. And most of those injuries occurred during the use or the passing of the devices. So in end of 2020, so in December of 2020 was the 20th anniversary of the Needle Stick Safety and Prevention Act. So just a reminder of come a long ways around this. This is an article I present every year because I think it's interesting, that looks at kind of the OR setting itself, and can we look at behaviors that may actually decrease the risk of exposures or sharps injuries. And in this case, they looked at teams doing surgical procedures, and they had what they call the Team Stability Index. And if any of you are interested in this, I think it's an interesting article. I'll leave you the reference here. You can pull it up and read in great detail. But when they found and they described teams that had worked together and had a good cohesive understanding of each other, communication styles, how people like to work, were those that had worked together for 6 months or more. And they found that in those groups, they tended to have far fewer sharps injuries than in those teams that had not worked that long together and had a lower stability index. They also broke this down by various surgical groups and or surgery types, and urology was somewhere in the middle again in this one, and you can look up the article if you want to see that. So, as I said, overall, the results showed some evidence for reduction of risk in percutaneous bloodborne pathogen fluid, that's BBF, exposure for teams who had the higher past collaboration index score. So they had worked together for 6 months or longer, all the team members. And mostly this was the association between team stability and risk of exposure to all of the surgical devices was significant when you removed the exposure to suture needles. When you look at suture needle exposure, the team cohesiveness or the team stability index was not as important. And that is probably more because that's the individual who is sticking themselves less than other dealing with other sharps. All right, so what you can do is avoiding use of needles where alternatives are available. Get involved in selecting and evaluating the safety devices. After all, you are the ones who need to use them. Use the provided safety devices. Don't recap needles. I should actually change this from avoid to don't recap needles. Plan your safe handling disposable sharps before any procedure. Dispose of used needle devices promptly in the appropriate containers. Report all sharps injuries promptly. It's very important for your health and protection, as well as for us all to understand where and how sharps injuries are occurring, because in order to really look at how we can prevent them, we need to understand how and where they're happening. And then report any observed hazards from sharps, participate in bloodborne pathogen training as you are, and hopefully everybody's had their hepatitis B vaccine. So this is also from the report from 2020 in the 20-year anniversary of the Needle Stick Prevention Act. And again, that the largest percentage of all sharps injuries occurred in the OR, with the greatest numbers being among physicians. So certainly all have a role in playing that. All right, I'm going to end there and pass this along to Dr. Russi.
I will do my best to pick up where Dr. Dembry left off. I'll mention just a few background statistics, and we'll talk about post-exposure prophylaxis, what it's based on, what are the recommendations, and what should you do if you get a needle stick. And we'll talk principally about HIV, but also about hepatitis C. So I'm putting up here first what's actually kind of a good news slide. The official number per the CDC still is, unfortunately, 58 healthcare workers have contracted HIV since the onset of the epidemic. But since 1999, there has actually only been one seroconversion that's been documented as an occupational exposure in a healthcare worker. And it's an exposure that took place in 2008, and it was to concentrated virus in a laboratory. There are a couple of really important things going on that have led to this substantial reduction. And one of the most important ones, of course, is that most patients who are HIV positive in the United States are getting good treatment and have suppressed viral loads. And so the source patient-based risk of transmission is much lower than it once was. And then the other is really that the standard of care these days in medical centers is that individuals who get a needle stick should be evaluated for that. The source patient should be tested, and antiretroviral prophylaxis should be given for a period of 4 weeks to individuals who are exposed to HIV positive blood. The most recent iteration of those recommendations actually was in 2013. From the CDC, and the CDC has announced that it's putting together a group to update those recommendations. As you can see on the slide, most of the seroconversions that have occurred in the past have been due to percutaneous exposure rather than to splashes onto mucous membranes or abraded skin. Most of the seroconversions have taken place due to blood exposures rather than exposures to other bodily fluids. And you can see the clustering of most of these events really kind of back in the 1980s and 1990s. A figure that commonly gets quoted is 0.3%, about a risk of 1 in 300. Again, that figure is generated from an era in the past when source patients tended to run higher viral loads, and of course, prior to the initiation of a standard of administering antiretroviral prophylaxis. The risk of mucous membrane exposures is lower than that, something less than 0.03%. And we don't think that there's risk associated with exposures to intact skin. Dr. Dembry mentioned the Needle Stick Safety and Prevention Act that was passed at sort of the very tail end of the Clinton administration. And there have been a number of studies that have actually shown substantial reductions when there's successful implementation of sharps with engineered safety features. Across the health system, we've been implementing these things since actually the early 1990s, and there are about 30 different devices in use that have some engineered safety feature on them. In the operating rooms, as Dr. Dembry mentioned, needle sticks are unfortunately still frequent. This was a study that showed how frequently they occur in surgical residents. And I would point out here that any study that has not taken advantage of a survey instrument or carried out direct observations is probably showing you the tip of the iceberg. We all know that needle sticks are underreported. This was a study that was based on an anonymous survey where people could reply, yes, this is how many needle sticks I had last year, this is how many I've had throughout my training period, and it probably gives us a much better estimate. And by the final year of training, 99% of residents had unfortunately had at least one needle stick. There have been a few studies that have actually posted observers at the operating room table. And this was one that was published many years ago. And the estimate was that in 15% of surgical procedures, a needle stick or a cut occurred. The intervention that's been shown to be most effective in the operating rooms in terms of an engineering solution is the use of blunt needles. And there have been a few studies that have looked at this. Any study that wants to accurately assay needle sticks needs to establish baseline data that are accurate. In this study, they actually spent 12 months observing surgeries to log how many needle sticks actually were occurring. So they weren't dependent upon individuals reporting the needle sticks. And then they implemented blunts. And you can see here that as the use of blunts increased, that the needle sticks decreased substantially. Obviously, blunt needles can't be used for all aspects of surgical procedures, but they are recommended as the first choice by the American College of Surgeons for fascial closure. I'm going to show just a few slides of some of the position statements of the American College of Surgeons. This is the one that addresses blunts and actually encourages the adoption of blunt suture needles for fascial suturing. We have unfortunately, the experience across the U.S. is that blunts have really not been embraced by surgeons, and we have done a few trials of them here. They have not been widely accepted among surgeons, and anecdotally, some surgeons have expressed the concern that they don't really want to sort of have two gears, that they don't want to be using blunts sometimes and sharps at other times, and perhaps forget that they're using a sharp rather than a blunt. But whatever the reasons are, they have not been adopted very successfully across the United States, despite the data that attest to the utility of doing it. Double gloving is also supported by the American College of Surgeons. Glove failure, unfortunately, as you can see here in the slide, is quite common, and double gloving adds a measure of safety. Hands-free technique is one where the data are mixed a bit. This was a study that showed that in surgeries where there was more blood loss, that there was about a a 60% reduction in Sharps injuries. This is another study that was done that did not show any difference when a neutral zone was used. And the ACS position on this is that it should be used as an adjunctive measure to reduce Sharps injuries, except in situations where it may compromise the safe conduct of the surgery. Sometimes surgeons have expressed that they don't want to take their eyes off the field to pick up something from a neutral zone. A partial hands-free technique can be used in circumstances like that, where the instrument is handed directly to the surgeon, but where the surgeon passes the instrument off to a neutral zone. Sharp substitution is something that has sort of evolved for reasons sometimes other than safety. And there are just some examples here: the use of electric cautery, staples, adhesives, tapes, blunt-tipped laparoscopic ports. And so there are a number of examples like this that I think sometimes get lost in the shuffle when people consider, what are the steps in the operating room that actually have been successfully implemented. Robotics, of course, another one. So what about prophylaxis? There actually has been no prospective trial of prophylaxis in the healthcare setting. Burroughs Wellcome actually tried to get one off the ground many years ago, and it didn't. And I think one of the reasons for that is that once you introduce the idea that a prophylactic medication could be given that might be helpful, people weren't willing to enter a study. They basically just wanted to have the drug. And so what we've relied on has actually been, most importantly, this study that was initially reported in the MMWR and a couple of years later in NEJM. And it's a study that Denise Cardo, who was down at CDC, did. And she looked at 33 healthcare workers who had seroconverted to HIV positivity following needle sticks, and 679 individuals who also had been exposed to HIV positive source patients, but who didn't seroconvert, and compared some of the traits. And as you can see here, things like deep injury, the device being visibly bloody, whether it was a needle that was placed directly into a vein or an artery, terminal illness in the source patient. These were things that occurred more commonly among individuals who had actually seroconverted than they occurred in individuals who had not seroconverted. And when these data were subjected to a logistic regression, these essentially were the factors that were still statistically significant. There was higher risk from deep injury, a visibly bloody device, a device that had gone directly into an artery or a vein, terminal illness in source patient, basically as an index of higher viral load. But importantly, if once the investigators looked at all cases under the logistic regression, the post-exposure use of zidovudine, which was the only drug available at the time the study was done, the odds ratio was 0.19, suggesting about an 80% reduction in risk. And this was the most important data used to justify the standard around administering prophylaxis. Another study that was cited was done in HIV positive pregnant women, and this was one that was halted midway through when it was shown that mothers who got zidovudine were passing HIV to their fetus much less frequently than mothers who got placebo. And the bearing that this study has on antiretroviral prophylaxis is when the investigators went back and sort of stratified by viral load, they found that at every level of viral load, that there was still a profound drug versus placebo effect. So it wasn't just that the number of variants was being reduced and fewer were getting into the fetal circulation. The suggestion of those data was that the antiretroviral being on board in the fetal circulation was preventing HIV from taking hold. And then there have been a bunch of animal studies that have been supportive as well. Initially, the follow-up time for a healthcare worker who'd been exposed to HIV was 6 months. With the newer 4th generation assays, the decision was made several years ago at CDC to endorse a standard that individuals should be followed for 4 months when exposed to HIV. Unfortunately, there have been some episodes of drug failure, and in general, those have been associated with resistance to the antiretrovirals that were given. And resistance is predisposed to by a number of different things. And let me just show this slide. This I borrowed from Mike Kozal, but it illustrates very importantly why the standard is to administer 3 drugs. Previous iterations of the CDC recommendations actually called for the use of only 2 drugs when it was a lower risk exposure, and they decided to dispense with that. And the reason is that single mutations are very common, double mutations are less common, but triple mutations are extremely uncommon. And to be able for the virus to encounter 3 drugs and to have a mutation that allows the virus actually to escape the effectiveness of 3 drugs is very unlikely. And that's the reason that 3 drugs are the standard. We're not going to go into drug toxicities in detail. The recommendation from CDC in 2013 was for administration of tenofovir and M-tricytidine. Tenofovir is a nucleotide analog, and in contrast to most of these, which are nucleoside analogs, and M-tricytidine is basically lamivudine with a fluorine group added so that it can be dosed once a day. Tenofovir alafenamide has been shown to have some advantages, and so we transitioned from the combination of standard tenofovir and M-tricytidine to a combination called Descovy of tenofovir alafenamide and M-tricytidine, which tends to be very well tolerated in individuals. The non-nucleoside analog reverse transcriptase inhibitors have not really been used, and the main reason for that is that resistance to them tends to develop quickly. Protease inhibitors in previous iterations of CDC guidance around post-exposure prophylaxis have been utilized, lopinavir, nelfinavir, a couple of others. But the current standard is actually to use either dolutegravir or raltegravir, one of the integrase inhibitors, combined with the tenofovir alafenamide and M-tricytidine. And so TIVK or dolutegravir is the standard that we use. It can be dosed once a day. It's been shown to be a little bit better as an integrase inhibitor than raltegravir. So Descovy and TIVK is essentially the standard that's used currently across the health system. There are a number of combinations like this. The recommendation from CDC, and I actually I sat on the panel for the 2013 recommendations, and there was some discussion, what's the time course? And the reality is we don't know. We don't know how soon you have to begin these medications in order for them to be effective. There are animal data that certainly suggests that it's better to start them within 24 to 48 hours. But the decision was to communicate something that would predispose to people getting treated early, like walk quickly, don't necessarily run, but get yourself to a clinic where you can get the medication started. And so what was used was within 1 to 2 hours. And I know that can present complications when an exposure occurs during a surgery, but that is the recommendation actually. And certainly needle sticks should be evaluated as soon as possible, because a good conversation needs to take place so that an individual can make a decision as to whether to start these things or not. And unfortunately, we don't always know whether or not source patient is HIV negative or HIV positive. And very often we'll start the antiretrovirals not knowing that. We have the data back a few hours later on the source patient, and we can stop the antiretrovirals if the source turns out to be negative, but we won't have missed that window of opportunity if the source actually turns out to be positive. Lots of opportunities at Yale, fortunately, for outside rotations. Not many of them have been going on lately, of course, due to COVID, but we're hopeful that they will begin again. And we want to make sure that anyone going into an environment where antiretrovirals may not just be sitting around on the shelves has access to them. And so I meet with anyone who's going abroad to provide them with antiretroviral prophylaxis and N95 respirators, et cetera, to make sure that they're supported if they were to have a needle stick. So just a couple, I know we're running low on time, a couple comments on hepatitis C. And maybe just a moment to digress here. The landscape with respect to hepatitis B, hepatitis C, and HIV has changed so much over the last 20 years. HIV, with the widespread treatment of source patients that makes them much lower risk, the standard for effective antiretroviral prophylaxis to healthcare workers has resulted in the data I showed you very early on of many fewer seroconversions. Hepatitis B, of course, we have a good vaccine to which most people respond. And hepatitis C, in recent years, the introduction of extremely effective therapeutics where 98 to 99% of people can actually have long-term clearance of the virus with use of those antivirals. There have been a few changes in recent years as to the follow-up of individuals who are exposed to hepatitis C positive blood or body fluids. The PCR actually becomes positive within 2 or 3 weeks of infection. And so the standard now is to, when someone is exposed, that the source patient's blood is tested by PCR to see whether they have actively replicating virus. The healthcare worker receives an antibody test at the time of the exposure, and then 3 weeks later, a PCR. And for many years, that was it. A couple of years ago, the CDC decided they should impose a second test at 4 to 6 months to make sure that a seroconversion hadn't taken place. And so that's the current standard. And generally, that test is done at 4 months at the time that the HIV 4th generation assay is done. Acute hep C is challenging to study because acute hep C is more often than not asymptomatic, and gathering the cases can be a little bit of a challenge. There have been some trials done, and certainly in the era when we were using ribavirin and interferon alpha 2b, it was clear that there were better responses when hepatitis C was treated early. These days, when the responses are so good with the newer agents, we may not be able to perceive that difference as well, but there is some ongoing work in that area. We don't prophylax folks with the newer hepatitis C agents, and the main reason for that is the cat isn't out of the bag, so to speak. You can still treat someone with these agents after seroconversion has occurred, and you can cure them. That, of course, isn't the case with HIV therapeutics, but it is with hepatitis C therapeutics. The one thing I'll mention about Hep B vaccination is that Hep B vaccination is now widely given in the population. It's generally administered, and then hepatitis B surface antibodies are not checked afterwards. So many healthcare workers who received it as high schoolers or in college won't have had their surface antibodies checked. It's important those surface antibodies do get checked. The challenge there is that over time, the surface antibodies can wane, but all of those individuals remain protected. So sometimes if it's been 10 years since somebody had the vaccine, you'll see a negative antibody titer, and you don't know whether it's this person who actually responded to the vaccine and came down, or whether it's someone who was a non-responder. So in cases like that, we'll generally boost once, and if they pop right back up, then they were probably this person and they are protected. And if they don't pop right back up, then we repeat the hepatitis B series to make sure that they're protected. Again, running low on time, but a couple of comments on infected healthcare workers. Unfortunately, there have been transmissions in the other direction, lots of transmissions of hepatitis B, sort of in the era before universal and standard precautions, and mostly from hepatitis B E antigen positive surgeons, where the viral replication is much higher than it is in E antigen negative individuals. There have been a handful of instances of hepatitis C transmissions from surgeons to patients, and we're aware of 4 instances of transmission of HIV. The Florida dentist cluster that some people have surmised was actually intentional, though there isn't direct evidence of that. And then the one that got the most attention was a transmission that took place in Paris from an orthopedic surgeon during a 12-hour procedure with an elderly patient. There have been a number of look-back studies that have estimated that these risks are extremely low for HIV, HCV, HBV positive individuals. The best work that's out there in terms of a standard for infected healthcare workers is from SHEA. It's actually a piece that Dr. Dembry was one of the authors on, and it looks at different surgical procedures and essentially proscribes surgeries for surgeons who have viral burdens of greater than 1,000 international units for HBV, anyone who is detectable for HCV, and viral loads in excess of 200 for HIV. As long as those numbers aren't exceeded, it's okay to do surgeries as long as advice is gotten from an expert review panel. So if a surgeon may harbor a bloodborne pathogen, they should make that known. The easiest way to make that known around here is to let me know. And then a panel is convened. This is all done confidentially. And that panel puts together the recommendations that need to be adhered to in order to continue practicing surgery. And those are essentially in accordance with that SHEA guideline. And they would include, if there actually is a rebleed into the field from a bloodborne pathogen positive surgeon, to actually make known to the patient that an exposure had occurred so that we can appropriately address the exposure with the patient. That is all I have. It's 8:28, and we can certainly take any questions if there are questions. Thank you all for your attention. We wish everyone well and safe